Hello everyone, this is Dr. Chandana Vishwanatham. So today in this video, I'll be talking about asthma guidelines, the MCQs which appear in MRCP Part 1 and Part 2. So if you have not seen my previous video on asthma guidelines, please go back and see the video and come back to answer the MCQs. And try pausing the video when I show the MCQ. After you pause the video, try to read the MCQ, write down the important points, and then try to answer the MCQ and write down whatever you think the answer is, and then again play the video to understand if your answer is correct or not. In that way, it will be an exercise for you to answer these MCQs. Don't just read the scenario and see the video continuously. So as I told you in my previous videos also, I'm making these videos for people who are not affordable for online expensive courses. So it will be helpful for them. So please subscribe to my channel and encourage me to make such videos. So let's start the discussion. So this is the first MCQ. The patient is a known asthmatic, is admitted to the accident and emergency with wheeze and shortness of breath, although she is not yet showing signs of fatigue, which means that she is not having a life-threatening or near-fatal asthma, and she is given continued nebulized salbutamol, IV steroids, and high-flow oxygen. This is the initial management that we give for acute asthma. So she is given all of those, and you are asked by the nursing sister in charge whether giving IV magnesium is appropriate. So, according to the BTS guidelines, which of the following would count against the need of IV magnesium at this stage? So, you have to know the indications of IV magnesium, which means that when do you give IV magnesium is important, because there are MCQs repeatedly asked over this topic. So in this question, they have asked which would count against the need of IV magnesium at this stage. The options are: patient is 18 years old, magnesium is at a lower end of normal range, tachycardia with heart rate of 120 beats per minute, patient is treated with oral theophylline, and peak expiratory flow rate is 240 versus 140 on admission, and now it is 240. So normally is 500. This means the patient is improving. From 142 he came to 240. So the question is which would count against the need of IV magnesium at this stage. So the first option is patient is 18 years old. So when considering magnesium infusion, the age is irrelevant and there is no relation to the age. So this option is not useful in deciding if you want to give the magnesium or not. And the second option is magnesium is lower end of normal range. So it is also irrelevant. We are giving the magnesium as a bronchodilator not to increase the magnesium values in blood. So the magnesium levels in the patient is irrelevant. And tachycardia with a heart rate of 120 beats per minute. If the heart rate is more than 110 beats per minute, as I told you, it is acute severe asthma, which means that even if this initial treatment is given, the patient is having a higher heart rate. It means the patient is having acute asthma, acute severe asthma. This will be an indication to give IV magnesium because it is not controlled with initial management. And the question is which would count against. So this is not the correct option. And the fourth option is patient is treated with oral theophylline. So giving oral theophylline means that there is a poor response to beta agonist therapy. So therefore there will be a possible need for IV magnesium also in these patients who are on oral theophylline. So coming to the next option, the patient has improved from 140 to 240 peak flow. So the patient is improving. So there is no need for magnesium in this patient. So this option would go against the need for IV magnesium at this stage. So this is the correct option. So you need to be very vigilant when you're reading the options, when you're reading the question, because the examiner can confuse you in many ways. So try to read the question carefully and try to read the options very carefully. So going to the next one. This is a 24-year-old patient who comes to the emergency department with acute breathlessness, and she's a known asthmatic, and she has a previous history of requiring admission for her asthma. She usually takes beclomethasone 500 grams BD. Over the past few days, her need for repeated doses of salbutamol inhaler has increased, which means this beclomethasone is an inhaled corticosteroid which is used as a maintenance therapy. But apart from that, whenever she has these symptoms, she will be using salbutamol as a reliever medication. So this need for this reliever medication has increased, which means that she is having uncontrolled asthma. So over the past hour, she has become increasingly breathless despite taking regular salbutamol. On examination of the patient looks tired and has increased work of breathing. Her respiratory rate is 40, which is very high, and heart rate is 110 beats per minute. Blood pressure is 105/75. Temperature is 37.2 degrees Celsius. Examination of her chest reveals generalized wheeze, poor air entry, and saturation is 86 on room air. So arterial blood gas, they have given some arterial blood gas values, but before going into this, you have to analyze which level of severity the patient is having based on her vitals. So the respiratory rate is 40 beats per minute, which means it is greater than 25 cycles per minute. So she comes under the level of acute severe asthma, and the heart rate is 110. If it is greater than or equal to 110 per minute, the patient is having acute severe asthma. So this is also in favor of acute severe asthma, and the blood pressure and temperature is okay, that no need, and oxygen saturation is 86% on room air, which is again very low. And so at this stage, the important thing is acute severe asthma versus life-threatening asthma. If you're having confusion with these heart rate, respiratory rate, and oxygen saturations, you can diagnose the patient by looking at the one important parameter on the ABG, that is PaCO2. If the PaCO2 is low, that means the respiratory effort is good and the patient is able to wash out CO2, which is acute severe asthma. But when the patient's respiratory effort is poor and there is building up of PaCO2 in the blood, there will be normalization of the PaCO2, which is life-threatening asthma. So that is the main difference between acute severe asthma and life-threatening asthma. So here the PaCO2 given is 5.1 kilopascals. So the normal PaCO2 is 4.6 to 6 kilopascals. So that there is normalization of the PaCO2. So the patient comes under life-threatening asthma. So the level of severity, they may ask you the level of severity in MRCP part 1, but in MRCP part 2, you will be expected to tell the most appropriate next management step. So as the patient is having life-threatening asthma, you analyze in that manner and read the options. The options are back-to-back salbutamol nebulizations and admission into a medical ward, and the back-to-back salbutamol nebulizations, IV corticosteroid, and admission into a high dependency unit, and IV hydrocortisone alone, nebulizer therapy, and later discharge from AR, or addition of a long-acting agonist to her therapy. So the appropriate step would be back-to-back salbutamol nebulizers with IV hydrocorticosteroid and admission into a high dependency unit, because the patient is having respiratory muscle fatigue and acidosis, that is normalization of the PaCO2, and established hypoxemia. So this vicious cycle leads to further respiratory muscle fatigue. So admission into a high dependency unit is it should be considered, and the patient may very soon require ventilator support and intubation as well. So but if this question is asked in the form of a chronic asthma patient, so in long term, she may need addition of a long-acting beta agonist to her therapy, and a combination inhaler such as salmeterol, which is a long-acting beta agonist with an inhaled corticosteroid, can be used in her long-term management. But this long-acting beta agonist for her therapy is not appropriate step at this stage of acute asthma. So in this stage, back-to-back nebulizations, corticosteroids, and admission into high dependency unit is needed. So, okay, going to the next MCQ. Here is a 34-year-old woman who is referred to the respiratory clinic. She has a long history of asthma since childhood and is maintained on a combination inhaler, which is fluticasone, which is inhaled corticosteroid, and a salmeterol. This is not salbutamol, this is salmeterol, which means it is a long-acting beta agonist. So she is on a combination of long-acting beta agonist and an inhaled corticosteroid. So on the advice of her doctor, she moved away from London to countryside and was well. Around 2 years ago, she had begun keeping a horse. Since then, she noticed a gradual deterioration in her asthma control and increased coughing up of mucus plugs. And she has been started on high-dose oral corticosteroid by her GP, although she feels her symptoms have not significantly improved. So addition of high-dose oral corticosteroids also did not improve her symptoms. On examination in the clinic, there was clear evidence of bilateral wheeze. Her peak flow was measured as 350 liters per minute. So in usually in adult males, the peak flow rate is 450 to 550 liters, and in adult females, it is 320 to 470 liters per minute. So in this patient, it is 350 liters per minute, which is okay. So, but her symptoms have been uncontrolled, and there are some investigations that are done. But before going to the investigations, I need you to remember that uncontrolled asthma, even with high dose oral corticosteroids, you have to consider the presence of bronchopulmonary aspergillosis, because the patients with asthma are prone to get this aspergillosis, and suddenly they become deteriorated or uncontrolled. On long-term basis, they have a good controlled asthma, and suddenly they become uncontrolled after they get this bronchopulmonary aspergillosis. So the question can be framed like this, and they will give you the investigations values where the immunoglobulin E levels are very high. The normal values are usually 100 to 200, and this is very high. And there is peripheral blood eosinophilia. Sorry, the eosinophils is not mentioned here, but there is peripheral blood eosinophils are high. And don't worry, they will give you the normal values here. The IgG precipitants to aspergillus are positive, and skin prick test to aspergillus is positive, and it's just X-ray. There is evidence of pulmonary infiltration. So they have given a clue to you that the patient is having bronchopulmonary aspergillosis. So in MRCP part 2, they may ask you to diagnose the condition, but in MRCP part 2, sorry, in part 1, they will ask you to diagnose the condition, but in part 2, they will ask you the treatment. So what is the following, which of the following represents the optimal next step in this patient? The options are increased dose of inhaled steroids, addition of an oral montelukast, stop oral steroids and start itraconazole, continue oral corticosteroids alone, add oral itraconazole to her regime. So for to understand this, you don't have to confuse first of all with asthma, which is uncontrolled, with aspergillosis. Because the investigations revealed the presence of bronchopulmonary aspergillosis, the treatment would be different from the usual asthma algorithm. So this is not the correct thing to do. Oral montelukast is also, if you're dealing with a patient with only asthma, so in that case you have to go into the treatment algorithm of asthma. But this is a different MCQ. This is completely different. You have to know about the treatment of the bronchopulmonary aspergillosis. So usually the treatment of bronchopulmonary aspergillosis is use of oral corticosteroids with prolonged course of itraconazole for up to 4 months. So as in the question, it is mentioned that the patient is already started on oral corticosteroids. So there is no need to stop the steroids, but we have to add oral itraconazole to her regime, which is a prolonged course of itraconazole. So this would be an appropriate thing to do in this patient. So going to the next MCQ. So here is a patient where you have been asked to urgently review a 24-year-old woman who has been admitted to the ER. She has poorly controlled asthma, for which she takes a combination of salmeterol, which is a long-acting beta agonist, with fluticasone, which is an inhaled corticosteroid, 2 puffs PD, and along with that, she's also taking leukotriene receptor antagonist, which is montelukast 10 mg daily. History of note includes 2 previous admissions to intensive care unit. On examination, she looks tired. Her blood pressure is normal. Pulse rate is 100 and regular. There is poor air entry and bilateral severe wheeze on auscultation of the chest, and peak flow on admission was 150, and this has only improved to 210 after 3 salbutamol nebulizers. Her predictor is 580, and the PaO2 is low, 7.8 on her ABG measurement. And they have also given a chest X-ray showing middle zone opacity, which could be due to pneumonia. So this could be the cause of worsening. It has made her asthma worsen. So you have to treat the pneumonia, you have to treat the asthma also. Both you have to treat. But the question that they have asked is which one of the following features would indicate a life-threatening asthma. So if you can remember the levels of severity, I told you that life-threatening asthma is when the patient having clinical signs and some measurement values. The clinical signs include altered conscious level, exhaustion, arrhythmia, hypotension, cyanosis, and silent chest, and poor respiratory effort. So clinical signs are okay, and coming to the measurements, the PEF is less than 33%, SpO2 less than 92%, PaO2 less than 88 kilopascals, and a normal PCO2. These categorize the patient into a life-threatening asthma. So in this question, coming to the options, the PaO2 of 7.8 kilopascals on air. So obviously this is indicative of life-threatening asthma. So we can move on to next options. PaCO2 of 4 kilopascals on air, which is low. Low PaCO2 means that the patient is having a good respiratory effort, and this is not life-threatening asthma. Distress, agitation, these are not features of life-threatening asthma. The patient will be exhausted. The patient will not be agitated. And the changes suggesting infection on chest X-ray. The presence of infection doesn't categorize the patient into life-threatening asthma. And pH of 7.46 is irrelevant to categorize the level of severity. So the first option would be appropriate thing. So I have again displayed the levels of severity because this is very important. The levels of severity and the treatment algorithm of asthma are very important. The levels of severity is regarding the acute asthma, but where the treatment algorithms which are important are regarding the chronic asthma management. So this is the next MCQ. So here is a 24-year-old woman who presents to the clinic with 9 months history of nocturnal cough and shortness of breath, particularly the first thing in the morning. So she works at the PA in a solicitor's office, and she is noticing wheeze on a number of days during the week. She is non-smoker, her weight is stable, but reports symptoms of reflux. So a salbutamol inhaler used PRN, which means SOS, whenever she needs, she's using it, and has had limited impact on her symptoms. On examination, her blood pressure is normal, pulse is normal, regular, her chest is clear, BMI is 28. So chest X-ray is unremarkable, and peak flow is 400, predictor is 480. So what is the most appropriate intervention of her asthma? So this patient is not having an acute attack. It is a chronic asthma control that we need to achieve. So she's also already using salbutamol inhaler, but she's having uncontrolled asthma. So what is the next appropriate intervention for her asthma? So if you can recall the treatment algorithm, the first thing that we need to add is a low dose inhaled corticosteroid. So coming to the options, omeprazole, propping up the head of the bed, regular salbutamol, regular beclomethasone, regular salmeterol, fluticasone. So salmeterol is long-acting beta agonist, so this is not indicated. Only we need to add a low-dose inhaled corticosteroid, so regular beclomethasone would be a preferred option here, along with whatever she's taking, the salbutamol inhaler that she's using is the most appropriate thing to start. So the treatment algorithm is very important. I have given this MCQ because I want to tell you the importance of the treatment algorithm. So this is the treatment algorithm which I have explained in detail in my previous video. If you have not seen the video, please go back and see the video, which is very important. Many questions will appear from this topic in MRCP part 1 and part 2 also. So going to the next MCQ. So this MCQ is a little longer, but this is very important MCQ. 31-year-old asthmatic woman. So she had been generally well, although she had not been sleeping well in the night due to coughing. She has noticed that when playing tennis, she is getting wheezy and requiring her salbutamol inhaler more frequently, at least 4 times a week. And she is on budesonide, which is inhaled corticosteroid, twice a day. So no significant past medical history, and she smoked 10 cigarettes per day and had done uh, so far for 2 years. An auscultation of her chest revealed mild expiratory wheeze, and examination was otherwise remarkable. So initially, when she came with these complaints, investigations were done, and the PEF was 80% predicted, which means she's having a mild asthma. And if VV1 is 85% predicted, and if VC is 90% predicted, she's treated successfully because it is a mild asthma attack, and she was treated successfully. And as her symptoms improved, she went back to tennis, playing tennis, and 3 months later, it has given that she was feeling so much better that she stopped her inhalers. 2 weeks after stopping her inhalers, she developed a chest infection which could trigger an asthma attack. So, due to chest infection, she acutely became short of breath. On examination, she is unable to speak full sentences. The respiratory rate is 30 and pulse rate is 115 per minute, and BP is 100/60. So, this respiratory rate, the pulse, and inability to complete sentences, all these indicate that she is having acute severe asthma attack. And the peak flow is 150 liters per minute. Her predicted was 420. It came down to 150, which is a significant reduction. And if you don't want to calculate the percentage, because 33 to 50 is acute severe asthma, 33 to 50% of PEF. If you don't want to calculate all those things, just based on respiratory rate and pulse, you can conclude that the patient is having an acute severe asthma. But to differentiate it from life-threatening asthma, we have to look into the PaCO2. The PaCO2 is 4.06, which means it is low, which means the patient is not having a normalized PaCO2 because of life-threatening asthma. The patient is having only acute severe asthma. So we came to conclusion that the patient is having acute severe asthma. So let's go into the question. Which of the following would be the best initial management for this patient? So as I've discussed the acute asthma attack management, I've told you intravenous aminophil and intravenous magnesium. These are only reserved intravenous magnesium. These are only reserved for patients who are not responsive to initial management. But the question itself is, what is the initial management? So these are not the correct options. And coming to this option, leukotriene receptor antagonist, I have told you that leukotriene receptor antagonists have no role in acute asthma. They have only a role in chronic asthma patients. So this is also not an appropriate option. High flow oxygen, oral intravenous steroid, ipratropium nebulization with salbutamol nebulization. This would be a correct option to consider for this patient. So the first option is the correct answer. Let's move on to the next MCQ. So here is a 31-year-old asthmatic woman, and she said that she has been generally well, although she had not been sleeping well at night due to cough. And this is the same question like the previous MCQ was there, right? So this is almost the same question, but there is an add-on thing in this, which is we have first treated the patient. The treatment was successful, and she goes back to home. She stopped her inhalers, and 2 weeks after the stopping of the inhaler, she had an acute severe asthma attack. And then we have given her initial management. Her initial investigations chest X-ray was done, and this is the chest X-ray that is fine. And this is the ABG that we have discussed previously, that the low PaCO2 concludes that the patient is having acute severe asthma attack rather than a life-threatening asthma. But this is an add-on thing that this is extra compared to the previous MCQ, is that she does not improve with the initial treatment, and chest examination now reveals quiet breath sounds, which means the patient has moved from acute severe asthma to life-threatening asthma. The silent breath sounds and repeat ABG showing a PaCO2 is increased. So 4.6 to 6 is normal. So patient is having 6.5. So the from 4.06 of acute severe asthma, the PCO2 has normalized in between, which is life-threatening asthma, and finally it has increased, which is near fatal asthma. So the patient has come to a stage of near fatal asthma. What do you do? What do you do next? The options are give intravenous antibiotics, which is not a relevant option here. Give more regular nebulizations, which is the near fatal asthma is difficult to control with these more nebulizations. Refer to ICU for intubation is preferred option because the patient is having PCO2 retention, which makes intubation as a better option for us. And starting non-invasive ventilation. So NIV in asthma is very controversial because it has been told that the NIV can increase the sputum retention and it can increase the bronchial hyperreactivity, and positive pressure in asthmatic patient can also increase the risk for barotraumas. So NIV is not a preferred option, uh, and particularly the patient is having retention of PCO2. So to prevent hypercapnia and complications of hypercapnia, intubation is better option in asthma. But if it was a COPD patient, we could have considered a non-invasive ventilation. But in asthma, you go for intubation rather than non-invasive ventilation. And trial of Heliox is not having any role in this patient. Going to the next MCQ, it is a 38-year-old woman comes to the respiratory clinic for review of her asthma control. On her last appointment, she was taking 200 mcg of beclomethasone, which is inhaled corticosteroid, and salbutamol, which is short-acting beta agonist. And she feels that unfortunately her symptoms are not significantly controlled, and she's coughing up at night, and this is the PP pulse, and this is the peak flow value. You can even calculate the percentage from the predicted value if it is mild, moderate, or acute severe asthma. But this clinical scenario is not something like she has presented with acute attack of asthma. It's not looking like that, so there is no need to calculate this percentage. Then there is wheeze or auscultation of a chest. What is the most appropriate next step according to the NICE guidelines? So I have told you the importance of treatment algorithm, and I'm telling you again and again that the treatment algorithm is very important. So the patient is already on inhaled corticosteroid and short acting beta agonist. So then what would be the next appropriate step? Add low dose oral prednisolone, add montelukast, add theophylline, increase inhaled steroid, add salmeterol. So as we know, the next option would be leukotriene receptor antagonist. So this would be a better option for this patient. Add montelukast. And this is another type of question which can appear. This is a 45-year-old non-smoking man remains breathless at nights with polyphonic wheeze despite already being prescribed a short-acting beta agonist by his general practitioner. He's concordant with treatment and has a good inhaler technique. And his spirometry result is showing a flow volume loop where there is an expiratory outflow limitation. If you can recall my previous video on pulmonary function test, I have explained the flow volume loops where there will be expiratory, this is inspiration, this is expiration, there is expiratory outflow limitation in this patient, and the patient is a non-smoker, so asthma is likely in this patient, and the patient is already on SABA, which is short-acting beta agonist. So what is the next appropriate therapy according to the NICE guidelines? So if the patient is only on SABA, we can add inhaled corticosteroid to his treatment. So it is very important to remember the treatment algorithm. And this is another question that has appeared in the exam. 24-year-old asthmatic is a salbutamol inhaler. She is using as and when needed. So this patient is on short-acting beta agonist and inhaled corticosteroid, but he's coughing up, and this means salbutamol is used at least 10 times during the week, so it is uncontrolled asthma. So what would be the next recommended thing to do? So the patient is on SABA and ICS, so adding leukotriene receptor antagonist can be helpful for this patient. So add oral montelukast with current therapy. These are repeatedly appearing in MRCP part 1 and part 2. So this is the basic thing that you need to remember in the treatment algorithm. Even if you don't remember the entire algorithm, let's just remember these 4 things. The first one is SABA, low dose ICS with SABA, low dose ICS SABA and LTRA, low dose ICS LABA plus or minus LTRA as a MART, which is maintenance and deliver therapy. And coming to the doses of inhaled corticosteroids, low dose means less than or equal to 400 mcg of budesonide or equivalent. Moderate dose is 400 to 800 mcg. High dose is greater than 800 mcg of budesonide or equivalent. And some things that you need to know about the leukotriene receptor antagonist, which is montelukast and zafirlukast. They have both anti-inflammatory and bronchodilatory properties, and should be used when the patients are poorly controlled on high-dose inhaled corticosteroids and long-acting beta agonists. This is previously recommended, but now if the patient is not controlled with low-dose ICS and SABA, we are directly adding LTRA to the treatment. So guidelines keep on changing, so it is important to keep updated yourself. And this LTREs are particularly useful in aspirin-induced asthma. This is important, and this MCQ can also appear like this. The patient will be started on montelukast, and after which the patient will have development of Chuk's-Strauss syndrome. They will give a clinical scenario where the patient is asthmatic and he was started on montelukast, and then the patient has developed the features of Chuk's-Strauss syndrome. So what could be the likely cause of this? They can ask. So going to the next MCQ. So this is the last one. A 55-year-old woman who is asthmatic admitted to the ER with wheeze, shortness of breath. She was given nebulizations, steroids and high flow oxygen, but she remains short of breath. So here also I have started with IV magnesium and I'm ending with IV magnesium. Here that question was which was against giving IV magnesium, but here which of the following would be a reason to give IV magnesium at this stage. So these two questions are opposite to each other. So in this question, the options are a peak expiratory flow of 49% of the patient's best peak expiratory flow after initial therapy. The second one is a repeat blood class showing PaCO2 of 3, magnesium at the lower end of the normal range, oxygen saturation is 93, and tachycardia with a heart rate of 105 beats per minute. So after the initial therapy, if the patient is having more than 110 beats per minute, we can consider magnesium. If the oxygen saturation is less than 92%, we can consider magnesium. So these two options are eliminated. And irrespective of the magnesium concentrations in the blood, we can give the magnesium as a bronchodilator. So this is also not an indication. And repeat blood test is showing PCO2, which is low, which means the patient is having a good respiratory effort and the patient is not worsening. So this is also not an indication. So this one, the PEF is less than 50% in spite of the initial therapy. So this can be the indication where IV magnesium is considered or appropriate. So this is the correct option. A is the correct option. So these are the different kind of MCQs on asthma that can appear in MRCP part 1 and part 2. So these videos are enough for the preparation. So I will be making some more videos on respiratory system. The upcoming video will be on chronic obstructive pulmonary disease, which is very important topic in respiratory system. After that, I will make a video on pleural effusion. So I am making these videos to help people pass MRCP easily. So please support our channel, please subscribe to my channel, and like, share the videos, and that will be an encouragement for me to make more such videos and make things easier for you, so that it will be a good thing that I have initiated these free videos, but I need your support and encouragement to go ahead. So please subscribe to my channel. Thank you.